most of the time in Seattle when we resuscitated people years ago, and we were doing so well, we still resuscitated 60%, but only half of those maybe went home. And the others had a couple days in the ICU, et cetera. So this is extraordinary. My mantra is the earlier intervention, the better results, and that's how good. So, an ounce of good pre-hospital care, or for you guys, it's a gram of, save a kilogram of ICU care, and that's a good example. So this, of course, set me up for ACLS, all the stuff I've just told you about. Does anybody know what ACLS is? It's an alternative clinical lifestyle, okay? So that's it. And this is circa 1990, though. So before the main talk, I will not get into the technologies that are out there, with the AEDs or pulse point that you can have an app and they will tell you there's a cardiac arrest, here's the nearest AED, go get it. There's things like that are out there, technologies. Other technologies such as KEE that people are trying actually in the streets, for example, in New Jersey, where you actually put transesophageal echocardiography down there and you can actually see what's the best hand position. You might want to go, because if you're up here, you might be blocking the aortic root. If you're down here, you don't know. So we may be starting to someday fine-tuning a little bit more how and where we put our hands on the chest, etc. This is just me just giving you a tease of what might be coming in the future versus, but there are people doing this now, just letting you know that. And of course, the use of possibly of Reboa out there is another thought. And then many of you have heard about taking it to the streets, so to speak, with ECMO. Traffic is so bad after this mayor in Paris made up some new rule that they just couldn't get back to the hospital time, so they said, let's take the ECMO to the streets. There are people who are actually doing different techniques for it now, whether it's, as I call it, one of our Eagles talks, ECMO Allegretto in Milano, or in places like New Mexico, they actually have a hand-cranked ECMO machine that they're using that they're trying out and bringing to the streets. So there's a lot of the activity that's going on out there. And that was all based a little bit on some of the work done by the people I work with, like Dr. Yiannopoulos, who's up in Minneapolis. And their first study, they put out that 42% of the people who used to be in refractory V-fib, who might have had a 6-7% chance of going home neurologically intact, they're getting it. Now, this is impressive, and it's hard to get to this point, and there are a lot of complications that occur, but they're sending people home neurologically intact, and that's so there's some really exciting things. We're going to see more and more trends for more and more ECMO going on out there, I think, in many places because of that. Okay, in fact, a good friend of yours, right, was in his home one day. He'd actually had some procedures for some kidney stones. I'm saying this publicly because he's talked about it publicly. He had some procedures and he started getting some DVT, thrombosis, deep vein thrombosis. And so all of a sudden one day, but he was on therapy for it, but all of a sudden one day in his home he felt really dyspneic suddenly. They called the 995 system there, and they came in, his own paramedics were taking care of him, and he says three things to him. He goes, PE, pulmonary embolus, right? VCU, that's his place where he works, Virginia Commonwealth University. ECMO. So the closest hospital was actually nearby, it was somewhere else. And they said, Doc, are you telling me this as a friend or as my medical director, to override the order? He goes, oh, no, your medical director. And he actually had a cardiac arrest within 6 or 7 minutes of getting to the place, and they did put him on ECMO, and here he is, he's survived since then. It's very cool. So, just to let you know, that's out there, it's happening, and so on, okay? So, here's today's talk. I'm going to review the focus on the quality of CPR, which most of you know, monitoring, compressions, and what I'm going to talk about today is a paper I just published on something I call the sweeter spot. Analyze why we need both evidence-based medicine and experience-based medicine. Okay, we're going to be wary of the fake news resuscitation, which is usually association. So if I told you the endotracheal tube was associated with a poor outcome in trauma, you'd go, oh, that's terrible. Maybe we shouldn't put him in. But it's not causal. It means it was associated with a sicker patient. Or a bout of hypotension with head injury, it was associated with that outcome. Well, no kidding, because it means you were sicker, that kind of thing. So a lot of times people, and even I'm going to show you that when it comes to the clinical trials that seem like gold standard clinical trials, there's a lot of faults with them, and we need to start appreciating that better and then start to reform how we do things. That would be the big message today. And I'm going to discuss adjuncts to enhance flow, not necessarily pressure. We've always talked about trying to keep coronary perfusion pressure up, and it may be that we need to enhance flow. And then finally, so I give a talk on it, and I go, don't mind the pressure, go with the flow, right? Okay. So, and then, so we'll talk about a bunch of things here, but the idea is that maybe some of the things we're gonna talk about are not, when I say revolutionary, it may be a revolution around the sun coming full circle back to the